guess we can start. Hopefully we're live now. Hi everyone. I'm Dr. Matt Miller. I'm back. It was a nice 2-week break where I was able to watch some fantastic discussions. I'm anxious to see how today goes because we have some big shoes to fill because the last 2 weeks were fantastic. If you don't remember, I'm a breast imaging radiologist. I trained at West Virginia University, did my residency and fellowship there, and now I am in Pittsburgh, Pennsylvania at Allegheny Health Network. Today we are going to discuss how to succeed in fellowship, and I'm real excited about the panel that we have today because we have a real good group of people. Most of whom, so 3 of us are a year and a month out of fellowship. Kimberly, my co-moderator, is just finishing her fellowship, so yay for her. And then we have Mitfa, who is Dr. Patel, who is the breast imaging fellowship director at Ohio State. So we have some real good perspectives today, and I hope you guys learn some stuff. So with that being said, I will pass it over to my co-moderator, Dr. Kimberly Beavers.
Hi, everybody. Thank you so much for logging in and for coming. Like Matt said, I just finished my fellowship, which was at Memorial Sloan Kettering in New York City. I am now about to start my job, which is in a hybrid program here in Orlando, Advent Health, where I'll be working with residents. And I'm very excited to have this discussion. Hopefully we can give you guys some good concrete advice for how to succeed in your fellowship. So I will let the other panelists introduce themselves. So I will start with Dr. Sumpkin.
Hi, everyone. Thanks so much for having me here. It's very exciting. So my name is Elisa Sumpkin, and I work with Matt over at Allegheny Health Network. And like he said, I finished a year and a month ago. I was at the University of Pittsburgh for both my residency and fellowship. And that's about it.
Great. Dr. Chan?
Hi, everyone. My name is Tiffany. I am one of the newer faculty here at UCLA in breast imaging. I did my fellowship here as well about a year ago, so I'm pretty brand new in that sense. I did my training on the East Coast though, so it's definitely possible to come out west, even if you've had all your training on the East Coast. And I served as part of our fellowship selection committee this past year. So it's been very nice to kind of see the other side of things. And I'm eager to share all that I know with everybody.
Great. And Dr. Patel?
Hi, everyone. I'm Mitfa Patel. I'm a breast imaging radiologist at Ohio State University. I did my fellowship at UPMC at University of Pittsburgh Medical Center in 2007. And I've been the breast imaging fellowship director at Ohio State since 2015. So thanks.
Wonderful. Thank you so much. So we're going to do some general advice from Matt, and I will try to keep it brief. We don't want to dominate the session. We want everybody's input. So we'll just say a few words, and then Matt will get into some questions and discussion topics, and we'll see where we go from there.
Sure. So I guess I can start with kind of general recommendations for people for success in fellowship. Bottom line, as with anything in life, my opinion, you learn the most important stuff in kindergarten, and that's try hard and do your best, right? And so at the end of the day, when you are entering any type of training or job, you're gonna get in what you put out. Or you're gonna get out what you put in. I mix that up. Whenever you decide to do any type of training, be it, it doesn't even have to be medicine, but we're talking about fellowship. So when you decide to do a breast imaging fellowship, you decide to put a deposit of time on yourself, on your training, and that deposit of time is a year. And in that year, you're going to learn a lot of stuff. And if you don't put in the effort, show up every day, rearing to go, wanting to get involved, then your return on that deposit isn't going to be nearly as great as it would if you did the opposite and show up every day and make sure that if there's something to be learned, you're learning it. If there's a procedure to do, you're doing it. So I mean, it's a real basic process and in that aspect. Now, getting into the nitty gritty of fellowships, and when I started, I wrote down a bunch of goals that I wanted to accomplish, and I separated my day-to-day stuff into 4 different categories: screening, diagnostic, MRI, because I was scared of breast MRI at the beginning, and procedures. And I had a list of goals in all of those categories. And, you know, I'm not saying that that's what everyone should do, but I think that was, as I was going along in my fellowship, I was able to tick off some of those goals. Okay, well, I'm comfortable reading breast MRI. Okay, if I'm not comfortable, maybe I should go take a course. And I did. I went and took a course. I want to be able to do procedures without, having my attending scrub in, with my attending just being in the room, and I was able to get there. And, just little goals like that, just setting them for yourself, along with the effort that I talked about, will really make you succeed. And so that's probably the biggest thing that I want to get across from my own experience today is, if you try hard, do your best, as Mrs. Taylor in kindergarten at St. Michael's used to tell me, you'll do well. And so I think that applies to breast imaging fellowship as well. So that's my spiel.
That's all great advice. I think that for general advice too, that's just a great thing to start with, is remembering that this isn't incredibly different from other training that you've done before, in that the same principles that probably guided you through college, medical school, and residency are going to guide you here, such as your character, discipline, hard work, what you're going to put into the fellowship. A few things that were helpful for me. I like to do a lot of reflection before I start a new project. So I kind of, before I started, thought about like, where do I want to be at the end? Where am I now? And where do I want to be at the end? And I was also scared of breast MRI when I started fellowship.
I think everyone is.
So that was a big goal for me as well. And then also, kind of, besides having these like kind of global goals, I kind of broke down goals into kind of like trimester goals. I grew up like going to a trimester system for school. So it's kind of how I think. So I had kind of like my fall goals, my winter goals, and my spring goals. And all of those can change. They're not set in stone. They're not things that you should feel bad if you don't accomplish, or if the way that you accomplish it is different than you thought before. It's just good to have those things actively on your mind. It doesn't necessarily have to be like a plan that you have to be rigid about. Just actively thinking about it. And then also just maintaining that curiosity, knowing that you learned a lot in your residency and you know more than you think, but also approaching fellowship with that beginner's mind, being very curious, being very eager, wanting to learn. And usually you'll learn a lot of different things from different attendings that you're not going to read in books. So just remaining open-minded to those things would be my general tips.
That's really great. I mean, those are. Does anybody have anything that they want to add to that? If anybody else wants to give kind of their.
I think one important thing about fellowship that's different than training is that you really need to take ownership of what you're doing. And we kind of discussed this before. I think it's easier as a med student or as a resident to kind of like tag along and, have the attendings kind of like decide things for you. And then you kind of look it up later, you figure it out. But as a fellow, I think what really helps in the beginning, having a mindset of like, okay, if I was here by myself and there was no one else here with me, what would be my next plan? What other mammographic views would I want? Would I want to go to ultrasound immediately? Those sort of things. And even if you're wrong, that's totally fine. That's how you learn. But I think mentally committing to a decision, and then, throughout the year, you actually vocalize it, of course. But you should always mentally commit to some kind of decision on this, mammo decision tree. And I think that really helped me, become more confident in my decisions, because slowly at the end of my fellowship year, what I was mentally committing to really reflected what the attending wanted to do. So I was like, oh, okay, maybe I'm not totally off. But, I think really deciding what you want to do with each patient, each biopsy you do, each loc or diagnostic, I think that helps you learn a lot in the very beginning.
That's great advice.
Yeah, I completely agree. Anybody else want
to? Tiff, you said that you wouldn't vocalize your your decision in the beginning. I would say that attendings welcome that.
Yes,
When residents,
absolutely, absolutely. I was just too scared.
yeah, you should feel confident. I think it was Kimberly that said, you know more than what you think. So, I look at a case when a resident or a fellow presents it to me, and I always say, what do you think? What are you going to do? So, and if somebody says it before, that's even great before I ask them. So, be confident. Like you said, you do know more than what you think. And, taking ownership of the case, like you said, is really important. So.
And it's funny being on the other side of things. I absolutely welcome trainees, like at least committing to something, like tell me something rather than being like, oh, like, I'm not really sure. And I love when, people are actually committing to a decision, because then we can talk through it, whether it's right or wrong. That's most important. Make a decision regardless.
Exactly.
Yeah.
And if it's wrong, it sort of cues the attending that maybe they're not teaching something correctly, or maybe right. Gap in your knowledge.
Absolutely.
So you can say, oh, why did they think that? So, if you don't vocalize what you're thinking, then, we may not be able to at all help fill in some of those educational gaps. So it's okay. And, it's okay to make mistakes. I think that we just want residents and fellows who are willing to learn, who want to work hard. And that's the most important thing. Now, if you walk in and you don't show any interest, I don't think any fellows would do this. If you don't show any interest, if you don't work hard and you feel like you already know what's going on, those are sort of the cases that attendings feel less obligated and incentivized to teach those types of residents. Does that make sense?
Absolutely. Yeah, I mean, definitely go into fellowship, eager to learn, because that, you're not, if you're not that way, then you're not only wasting other people's time, you're wasting your own time, because you could get a job outside of residency without doing a fellowship.
Yeah, in fact, when I was interviewing for fellowship years ago, somebody told me that. They said, think of this year as your, I don't know what attendees make, $300,000 gift to yourself. Right?
Absolutely. Yeah, right.
Could actually go out and make that much money, but you were not. You were making less money because you're investing in yourself. So when they said that, that really sort of clicked. And this is your gift. You're investing in yourself, and make sure you make the most of the year.
That's such a good point. Such a good point. And I mean, it goes back to what I was saying at the beginning, where you're only going to get out what you put in, and if you don't put in the effort, then your return on your $300,000 investment is going to be in the red, right?
Yeah, so also I think something specific to breast fellowship that I thought was really important was not only your relationship with all of your your co-fellows and the residents and the attendings, but also the techs. The techs are so important in everything that you do. So I really took a lot of time as I try to now, of course, but then to really get to know all of my techs and learn from them, because I mean, they know so much. They taught me a ton, and really just taking the time to go in with them, get as much information that I can from them, and work side by side. And we work just very closely with them, and more so than a lot of the other parts of radiology. So I would definitely stress that.
Yeah, and your ultrasound techs are amazing teachers too. They're the ones really how to scan and all the tricks that are involved in that. So spending a lot of time, I mean, obviously the mammography techs are wonderful too, but I find, residents and fellows spending some time specifically with ultrasound techs is really helpful.
No, and I mean, I can speak from personal experience. Just, I had fabulous teachers down at WVU, and but it's a very, very busy practice, and I was the only fellow. And that was part of the reason I wanted to stay there and train there, because I knew how busy it was. I knew I was going to get exposed. But at the same time, a lot of, not saying that my attendings were great teachers and I learned a lot. I'm thankful for everything that they taught me. But sometimes, I would have to take the time to go grab a tech and, hey, can you show me how you did that, while the attending, attends to other things that they're doing, because they're spread thin. And, if you establish that relationship early with the techs, both mammo and ultrasound, and even MRI, they can, show you things that, maybe attendings don't even know, because there are like little techniques that they know, that, little tricks to the trade. And sometimes the attending just sees the image, You know,
Absolutely.
it's like, you know, so I still use some of those tricks on day to day when I'm doing my own handhelds and stuff, and handheld ultrasounds. And, you know, I think back to, you know, what some of the techs down at WVU taught me. And it's really, you know, invaluable to your training, not only learning from the attendings, but learning from the techs and the nurses too.
And you never know where you're going to end up, right? So if you end up in a place, maybe more rural area where the techs are not as specialized, you might end up having to show them those, you know, those tricks that you learned, positioning tricks from your technologist, because, you know, chances are if you're doing a fellowship, it's at a place where you have, you know, techs that are dedicated to breast imaging. So, you know, you might be teaching them next year. So it is important to learn those tips and tricks.
Yeah.
Absolutely. Just a quick anecdote, our MRI techs in my fellowship helped a lot as far as positioning for tricky MRI biopsies, which I found to be not intuitive at all. And so it was very helpful for them to actually walk me through it step by step and show me how to do it, because it was not the way that I thought that I would do it. So I was very, very grateful. So they have lots of stuff that even you're not going to read, even if you read a textbook on the subject.
And you're not going to get that in residency either. I mean, maybe, but you know, the chances are less likely. In fellowship, you have a dedicated year to learn breast imaging, and that encompasses everything about breast imaging. And so, you know, you should, as Tiff said, you know, you should take it upon yourself to kind of be autonomous and grow in that autonomy. But at the same time, you know, take some time to learn the minutia of your craft, because, you know, you don't get that at any point else in your training and, you know, outside. You know, I can't just leave the breast center and be like, hey, I really want to go see how they did that in the MRI scanner and walk down to MRI. You know, it's not conducive to what we do, you know, day to day as a attending. But when you're a fellow, you can do that.
Yeah, that's definitely true, Matt. I think it's all about learning the details in your work. You really fine tune your skills, particularly in the latter half of fellowship. And that's funny, you know, you're saying the MRI techs, they taught me so much in terms of, you know, details and positioning, and they were there for a while and they're so good at it. So I took away a ton from that. I think that I kept trying to think, what would I do if this went wrong, or if this problem happened? You know, especially in the last few months, I kept trying to figure out all the most difficult scenarios that could potentially happen, and then asking everybody around me what they would do if that happened. And because I think that's a big part of breast imaging is just, you know, you are troubleshooting, particularly in some of your procedures, which is what I love about it. But, you know, it's a craft. So,
and let me just say, Elisa, thank you for me and you having that open conversation. We bounce off each other all the time. I mean,
oh yeah.
I call her my second, and we have another, Sarah Thomas. I call them my second and third brains, because whenever I have you know.
Yeah.
No, definitely. I mean, fellowship is the time to learn every crazy scenario that you can, and nothing's going to really prepare you for the real world. I was still shocked at all these weird cases or situations that I did not even like somehow see in fellowship when I first started.
Yep.
But definitely fellowship is when you want to, quote unquote, you know, like make mistakes or see what happens when you target the wrong thing, or, you know, anything like that, because at least you have backup at that point and you can always learn from that. You don't want it to happen when you're like on your own, you know, out there. Yep. And so really it's a good time to learn like the worst case scenarios. You don't want to have just easy biopsies. You can handle that. You know, you want to have like complicated cases so that you're prepared for when you're on your own.
Absolutely. Absolutely. And let me, you know, in that theme, I'd like to apologize to my fellowship director for that bleeder that she knows that if she's watching this right now. But, you know, I made a mistake and we, you know, we learned from it, and, you know, I'm a better breast imager from it.
And now you know what happens.
Exactly. Exactly.
If you don't have complications, it means you haven't done enough procedures, unfortunately.
No doubt.
Yes.
We're always going to have those problems. And Alyssa, I think that that's a great point that you made about asking somebody, what would you do in all of these bad scenarios? And sometimes if I have a day of biopsies where everything goes very smoothly, I actually start telling the resident, well, today everything went the way it plans, but this is what you do in this case if this goes wrong. And so I try to go through all of those scenarios, but it's best, unfortunately, if you're there and you experience that and you watch the attending work through it. But
no doubt. Well, I mean, we can shift gears a little bit. I have some questions that we can kind of go through and just kind of discuss things. I guess we can start. Why don't we go through and what basic question that I guess you get when you interview for a job or interview for fellowship? Why breast imaging? Why did you all choose to do a breast imaging fellowship?
Oh my gosh. I mean, I feel like a real doctor.
Someone had to say it, right?
I mean, obviously I love imaging and, I love radiology in general. But there's a part of me that kind of missed seeing patients, throughout residency. And I really liked having, like someone's imaging and then like meeting them in person, like having that connection also made me feel like I was doing a lot for somebody, something like that. And being able to also the logistics of breast imaging, the procedural aspect, I did a surgery intern year and I always felt very accomplished every time I did a procedure, even if it was like an intern level. Sure. But being able to do procedures under different imaging is like so fun, so cool. You're really helping the patient. And then most importantly, in my point of view, we get some really good continuity with people, we get closure on the people that we call screeners back for, or that we work up for on a diagnostic. It's much more easy for us, I think, to see those patients again, or maybe our colleague does, and we kind of tell each other. And we find out, what did that end up becoming? Oh, you ended up following that and blah, blah, blah. So I really enjoyed that continuity aspect. All of those things made me really feel like I was combining like radiology and clinical medicine. It was really like the perfect blend. And if that's something that you enjoy, you would love breast imaging too, I think.
Yeah, that's great. I think that's one of the huge reasons that a lot of people do it. I love patient care, and it's just a perfect balance of imaging, seeing patients, and really being so hands-on. You get to do all of these procedures, which can be a lot of fun. I've kind of always been exposed to it. My dad is a breast imager also, so I've always sort of had it in the back of my mind, but that was sort of just something in the background. Maybe it's in my blood, I don't know, but
it's definitely in your blood. Own it.
Yeah, it must be. I don't know. But I also really kind of always enjoyed primary care in medical school. But so for me, this was sort of a combination of the things that I loved. I get to do this very subspecialized primary care in a sense, and then combine it with imaging as well and procedures, because I love hands-on things. So I think it's the best of all worlds. I really love it. I think it's a perfect fit, and there's nothing else that I'd rather do.
I think all of those things, the patient contact, the people interaction, biopsies, but I also like that it's a rapidly advancing field. I think it's really exciting. Years ago, there was just, ultrasound and mammography. They had MR. Now we have screening ultrasound, contrast mammo. There's a lot of new technology. And I think it makes it really exciting.
Definitely. I agree with all of those points. But also I would say something that attracted me in addition to all of those things was kind of the advocacy component of it as well, because advocating for women is like very important to me personally. And I've always felt that was like part of my totem pole of who I want to be. And so going into breast imaging kind of helped me to really be able to use that and to really be able to help women in my daily life and kind of live my principles. So that was really important to me as well.
Definitely. And one, so I think we've kind of hit all of the high points of breast imaging, how awesome it is and whatnot. And I was a late bloomer as far as choosing radiology. I went to medical school thinking I was going to be a pediatrician, and took a radiology course early in my fourth year, and just kind of turned my world upside down. And then I was thinking, well, do I really want to sit behind a computer all day? And that was before I really knew what radiology kind of entailed. I like the subject, I like the anatomy, and I was kind of jockeying as far as, okay, do I want to give up all that clinic time that I was planning on doing for the rest of my life? And breast imaging, and along with all some of the other clinical base, IR is another one where you see there's a lot of patient care, more on, breast imaging. I always say, if you like outpatient medicine and you're a radiologist, do breast imaging. If you like inpatient medicine and you're a radiologist, do IR, with some overlap with MSK and abdominal imaging and chest. So, I was already thinking breast from that standpoint. So I wanted to open up a clinic somewhere as a pediatrician. And then my wife got breast cancer when I was a first year resident. And, I kind of turned a negative into a positive. I was already thinking that direction. And I was like, okay, well, this is fate telling me I need to go down this route. And I really, nothing else kind of swayed me. I flirted with body and considered MSK, but breast imaging was always primary for me. And, so, and realist, so she's 5 years, she's a 5-year survivor. Shout out to my wife, Liza. Congratulations. 5-year survivor on June 30th. And that was, at the end of my first year of residency. And being able to go through that with my wife, have that emotional experience and, see, a breast imager saved her life. She turned out to be a BRCA2 positive with no family history. 10% of BRCA patients are spontaneous. And so if they wouldn't have found that breast cancer, it could still be growing in her right now. And, seeing that impact that Dr. Lane and Dr. Shahan at WVU did for my wife was just, turned my world upside down. And I use that experience, in my day-to-day relations with my patients. And, I know that I'm, unique in that aspect, that I've been able to witness that firsthand with a loved one, with my significant other. But, you use what's available to you. And I use that every day. So that's another thing that, I wouldn't wish that on my worst enemy. I don't have a worst enemy, but if I did, I wouldn't wish that on them. But being able to turn that negative into a positive is something that's near and dear to my heart as well. Anything else that I think we pretty much covered that. Does someone want to talk about, there's some misconceptions out there, maybe not misconceptions, but some clarity maybe needs to be made. There's a lot of different flavors of breast imaging fellowships because it's not an ACGME approved or accredited fellowship. There's programs can make their breast imaging fellowships what they want them. I trained at WVU where it was primarily, I did my day-to-day work. I had no general call whatsoever. It was just straight up breast imaging every day. And then I did some moonlighting as a chest imager, and I didn't know at the time, but my future job, that was going to be the extent of my call was chest x-rays. So my moonlighting was preparing me for the call, which was fantastic. But then there are also some other different flavors of breast imaging and quote unquote women's imaging fellowships. Does anybody want to talk to those?
Sure. Yeah, I can just go over my personal experience, and then maybe the others can share theirs as well. So at Memorial, it is a breast imaging fellowship predominantly. About 2/3 of the time are spent in breast imaging, and about 1/3 of the time is spent in body oncologic imaging. And then we also have a 6-week period of elective where you can do either more breast in an area where you want to get stronger, or body MRI, or ultrasound, or any other area that you're interested in. But I know that some fellowships are more geared towards women's imaging, meaning incorporating ultrasound and even female pelvic MRI as well. And others are completely split breast body, like across the street at Cornell, where some of my colleagues were in their fellowship. So there's lots of different flavors, and it's somewhat confusing, but as you are in the journey of applying for fellowship, just definitely check the website and then ask them on your interview day, because it's very, very helpful to know exactly what to expect before you're going into a program.
At UCLA, we have 2 different types of fellowships. So we have a dedicated breast imaging fellowship, which is what I did. And that's, all 12 months are breast imaging. Now we do take general call as well throughout the year. So, I'm still brushing up. I was still able to brush up basically my body skills and like ED studies and that sort of thing. And then we had another, women's imaging fellowship that was like fairly new. And that's, I think, 6 months of breast imaging, then 6 months of body, with obviously emphasis on female imaging. I think it really depends on what you envision for yourself in the future. Obviously, these things change and no one really knows 100%. I didn't know 100%, even though I kind of always geared, towards academics because I like teaching, I like research. I love the whole vibe. So for me, I knew that I really wanted to do mostly breast. However, if I wanted to do private, I felt like my on-call experience throughout the year would have also been useful. I may have been more scared if I had done 12 months of breast, no general call, and then went to a private group where I had to do other things. But then I probably would have sought out other opportunities to do call. And I'm sure many people would have been excited for me to join the call pool, So
Absolutely.
Kind of just depends on what you're looking for, I think. But that was my experience.
Yeah, I agree with that. It's kind of similar to UPMC. It was about a quarter body, kind of general, excluding neuro and MSK, but there was some nukes in there as well. And then the rest was breast imaging. It does, I think, kind of depend on what you want to go into, but it's hard to tell exactly what you want to do in the beginning. It's a tough decision, and I think at least I sort of struggled into, should I learn more just for job security purposes? And then also I did like body, not as much as I like breast, but I kind of held on to that a little bit. I wasn't quite ready to let it go. And I'm still kind of there now. My call actually does consist of some body imaging. It was a combination, and I did like it, but I think it's, if you know what you really want to do and how you want to practice, it's ideal, obviously, to kind of figure that out before then. If not, I think, it always works out in the end.
Any input from our resident fellowship director?
Sure. Well, my experience was also, I did the same fellowship that Alyssa did, where it was a women's imaging fellowship. I really didn't know what kind of job I was going to end up in. And then I ended up coming to OSU and being a breast attending, where I do 100% breast. So in that sense, I have not really been able to use some of the skills I learned from the women's imaging standpoint. So that's something to think about, but it is really hard to determine what you're going to go into. So that's something that I tell people that come in and interview, that, you don't really always know whether you're going to be in a private practice job or an academic job, and just making sure that whatever fellowship you have is able to train you in both. So at OSU, it's a breast only fellowship, and we do 11 months of breast imaging and then a month of an elective where you can rotate through breast surgical oncology, pathology, radiation oncology, plastics. So you get an idea of the other side of breast imaging. So I think that that's a nice elective too. And I don't know, if that's something that people can ask if that's possible at their program too, because I think it's really important, the other side of what's happening in breast imaging.
Oh, that's great. That's absolutely great. So, I originally in my fellowship, I was going to spend a month with surgery and pathology, but things happened, and I had to take a couple of weeks of leave because we had a family emergency or whatnot. And we just decided to stay just 100% breast imaging. I wish I would have had that, to be honest with you, but it's just the logistics didn't work out. And if you go to a program that has those electives, that's very beneficial. I really think, there's no wrong choice in fellowship. It's kind of like residency. I'm associate program director, and I tell residents and medical students to find a place where you feel comfortable. And that's, that can be at a small program like WVU or Allegheny Health Network, or a big program like Memorial Sloan Kettering. As long as you feel comfortable at that place, you're gonna, excel in, what you're trying to learn. And you're going to find places with fellowships have good attendings. There's going to be bad eggs everywhere too, but most of the places that you go to are going to have great attendings that you'll be able to find a mentor, find a couple mentors, and people that are interested in your success. So the whole women's imaging with body and general call versus a strictly breast fellowship, there's no real wrong answers based off of, if you do see yourself going into a private practice gig, if even some people get recruited for private practice gigs even before fellowship. And, if you see yourself going that route, then it would probably behoove you to do a fellowship with a little bit more general call than one that maybe like I did, where it was just straight up. I'm not saying I can't have a private practice job, but my fellowship was more geared towards academic breast imaging. It's on. No one can predict the future, but yeah.
The one interesting thing too on the flip side is that I know some places where if you do women's imaging, like 6 and 6, for instance, and you get hired for a full-time breast position, they may ask you to do a few more months of dedicated breast imaging. I have heard of that happening. So that's kind of like the flip side, where
Sure.
like, you kind of plan to do private practice maybe, but then you had a change of heart and you wanted to go into academics. And then they may want you to just spend a little bit more time before starting as an attending. So that's always a possibility too.
It's a good point. That's a real good point. I've heard of that too. Yeah, I mean, does anybody else have anything to add about that? I think we pretty much hit most of the stuff we need to hit on that. We did get a question from a reader asking about how they can go about getting effective feedback as a fellow to a staff. Am I reading that correctly, Kimberly?
Yeah, so someone asked how to get effective feedback and use it towards your education. I think it's a very great and nuanced question, because I think that both giving and receiving feedback are some of the most challenging things that you'll do during the day. And so I think that it's a really good place to start as a learner is, of course, asking for feedback. And if they say, well, you're doing great, that's good, but ask them for something. What could I improve on? Is there something that I could read about this topic that would be helpful? Kind of asking for specific feedback from your attendings, I think, can be helpful. There's also a really good book about receiving feedback, and it's called Thanks for the Feedback. So if you have trouble receiving feedback, or if it's been difficult for you to kind of give and receive feedback, it's really good. So I would highly recommend that as well.
Sure. Yeah, I think, you're there to learn. And, if you were an expert breast imager, you wouldn't have to do a fellowship, right? And so, you have to kind of check your ego at the door. You're going to be wrong, especially early. And, don't take it personal when a staff says, no, that's completely wrong. No, that's a cyst. You want to biopsy that? No, that's a cyst. We're not biopsying that. And, I said that I always say I had kind of two different flavors of fellowship. I had, I call it pre-polar and post-polar. If he's watching right now, I'm sure he's laughing. But there was a guy who he actually used to be the head of breast imaging where Elisa and I currently work. But he left there and took kind of an adjunct position down at WVU and started halfway through my fellowship. So pre-polar, I was being taught by two women, one of which who was taught by Dr. Poller. And then he comes down and he's, the two staff that I had other than Poller were kind of soft-spoken and, we had a very good rapport. He comes down, he's this brash older gentleman who's like, if I got something wrong and, Ginger would be like, oh, well, this is what I think. Dr. Poller, no, that's wrong. That's wrong. What are you doing? No. But, it was all out of love. So different staff give feedback differently. And as a fellow, you want to be open to all different types of feedback. I worked with 3 or 4 different staff as a fellow. Dr. Brazzi, want to throw her in there as well. And there are some people that work. I'm sure Kimberly, at Memorial Sloan Kettering, you had probably tens of, maybe 20 staff. I don't know. I've never been there.
In the 30s.
In the 30s, yeah. You know what I mean? So everyone does feedback differently, and some people are more soft-spoken than others. And I always tell residents and fellows that I work with, I'm like, okay, put your money down. If all these options are laying on the table, where are you going to put the money? And I'm not a gambler either, but that's how and if they're right, I say, okay, you get your money back and then some. Okay, nope, I get your money now. And that's kind of how I do it. But
one of my favorite things that I received as feedback would be if I was going through a case with an attending and I told them my thought and, like put it out there and like gave them my opinion, like my plan. And if they said to me, I disagree with you and this is why, and then walk me step by step through the thought process, because I think like Tiff had mentioned earlier and Mitfed had mentioned as well, and Elisa, like everyone has said it, breast imaging is all about troubleshooting and what's the next step and thinking 3 steps ahead. So that type of feedback at the moment is also incredibly useful.
You know what's interesting? I think one feedback that I really wanted in fellowship was about screeners. So reading screening mammograms, you kind of read it on your own and then you put it in the queue for your attending. But a lot of the times you're kind of like, I don't know if I should make that call. So I'm just call it like negative. But deep down, you're like, I don't know what I would do if it was on my own. And the attending just signs it off, right? And you kind of wish you had a discussion with them. So when I was a fellow, I felt like it'd be useful if you say, hey, by the way, if you guys, see anything, please let me know, or I'd be happy to go over them with you as well too. Because that was something that I was really afraid of when I first started as an attending, was just making final calls on screeners. And a lot of the times, it can be very transparent. Obviously, if I call something back as a fellow and the attending doesn't agree, I just follow up on it and I'll realize that, or maybe they'll tell me. But I think that's one area of feedback that would be very useful for all fellows, is to really follow up on their cases and ask their attendings too, to say, hey, do you think that like I'm overcalling all these asymmetries, or like every time I see this, I think this, like have a good discussion. And that kind of feedback for this specific area, I think is super useful. At least it was for me. So.
That's a good point, Tiff, about screeners. I think attendings have a tendency to think that screeners are easy, but they're actually really difficult, right? So, and we also have a tendency to think that the fellows are very equipped to go through screeners. So I've recently actually changed the way I staff out fellows, and maybe this is something that people who are in their fellowship, they can ask their attending if they're okay with this, is that I don't go through every case with the fellow, but I just have them make the pile or their notes where they say, you know what, I didn't call anything on this, but I just want to staff this out in person with you. And so, it tends to only be maybe 10% of the cases. And so the attending doesn't mind. It's not that much, 100% of the cases, but it's just those ones, even if you didn't call anything, you just want to see your attending go through, and then you see, oh, they didn't even look at that.
Yeah, exactly.
So
yeah.
It doesn't matter. So it's nice to see somebody else go through that process. So you don't have to do 100% of your cases like that, but I've started to do that with the fellow just to give them a little bit more, autonomy too.
Yeah, I completely agree with that. That's a really good point. I felt like in my fellowship, people kind of assume that you know what's going on and that you know what to call, and that is not true. Particularly in the beginning. And honestly, I got this from a few attendings that I worked with, but definitely not a majority, where they would go through, a small pile and actually, tell me what their thought process was. And even for the, particularly really in the beginning, but even those negative ones, the benign ones, just hearing them think out loud, I think is very effective, and definitely something you want to engage in if people aren't doing that for you, to even request to do just a pile of them here and there, because I honestly still think it's one of the harder parts of the job. And I think it's one of the scarier parts too. So just putting in your work and really picking people's brain about that it's very important to the whole fellowship.
No doubt. We're talking about, Tiff, you were talking about following up, and I thought that was a good segue into bringing one of my visual aids. This is this is my procedure log that I wrote down all the pathology on and followed up. And that's another good recommendation. I thought I got a lot of use out of that. I made lectures off of this, and helped resident education. So yeah, that's another thing, that's awesome about breast imaging is that continuity and being able to follow up on stuff. And I wrote everything down. I mean, today's computer world, technically I could probably go print off a list or something, but I have tangible evidence right here in this book. And now it's a keepsake. I can show everyone how much work I did as a fellow.
And your PAC station is your best teaching file, right? So anytime a technologist brings in a case where it's like, oh, the patient had, IDC 4 years ago, go back and see what that IDC looks like. I'm sure that most people do that, but just as a reminder, it's your best teaching tool is having your station there. So make sure you go back and do that too.
Absolutely. Switching gears a little bit, we talk about what it's like being in fellowship, and we can touch briefly. We don't want to get too much into this, but is there any advice you guys would have for prospective breast imaging fellows? So people, either residents or medical students, or even people that are looking to go to medical school thinking about breast imaging. We've talked about the benefits of it. Is there anything, out there that you would recommend them doing before they, decide to go into breast imaging? Crickets. Shadow of breast imager. I'll start. Shadow of breast imager. If it's never been a breast imaging, shadow of breast imager, and get to know. I know COVID times that's kind of impossible right now, but once I talked to a bunch of high schoolers last week, and I already had one reach out to me and want to shadow me, and unfortunately she can't right now. But that's if you're looking to do breast imaging, you want to see if this talk has piqued your interest. Come spend some time in the breast imaging center. And then, for residents, if you decide after your breast rotation that breast imaging is for you, as with any fellowship, I mean, if you want to do MSK or whatever, go talk to the people there and let them know that. And so, the attendings can have you on their radar for, even research that comes up and projects that come up. They know that, hey, Joe Smith wants to do breast. And, those are probably two big things: spend time and make it known.
Those the research projects that you're talking about as a resident are actually a very they're a good sneaky way to get to know your attendings, especially some of the more senior ones that may not have as much, let's say, clinical time, but they're like the section chief or something like that. I mean, that's what I did in my residency. I happened to do a project with our section chief, and then I got all this time with her to chat with her about things, to learn things. And I felt like this was an opportunity I may not have gotten on service because she just wasn't, on rotation as much. And she was able to end up writing me a letter of recommendation. So there's a lot of practical purposes too on who you end up doing projects with. Of course, do projects that you're interested in so that, you're motivated to actually complete these things. So you don't, go on interviews and be like, oh yeah, I did do that project, but it didn't turn out to be anything. You got to have something to speak for yourself. But if you do it with the right people, they can help you out.
Networking just takes care of itself,
it's
right?
It's part of networking.
Yeah, absolutely.
I think that as a resident, if you're interested in it, my biggest advice would be to get your hands dirty. I mean, go in and ultrasound yourself. Go in with a tech. Be the first person to do it, and then the tech can ultrasound again afterwards if they need to. But really be hands-on and try to be a little bit more aggressive in your learning. Because other parts of radiology, I don't think it was as much like that. But when I was a resident, I mean, I just loved it. I actually got to do things with patients, and I would get in there and actually learn how to use the ultrasound machine, which I wasn't really using elsewhere. But I had a lot of fun with it. And I think then it shows that you're interested. And that you really want to learn. You get a lot out of it. And then just as we started out with Matt saying, you're trying hard and people see that. So I think that's super important.
Yeah. And perhaps I'm speaking from a place of just great luck or just great circumstances. But when I was in medical school, my husband started his radiology residency. So I was exposed to radiology very, very early. And he was able to help me meet some different people in radiology, and I started shadowing a breast imager. You definitely don't need to be married to a radiology resident to do that. But it was just something that made it pretty simple. He just helped me up and get me started. And I actually met the breast imaging mentor who really guided me all the way through medical school and through applying to residency and starting the process. So even if you're a medical student, it's never too early to go just check it out, see what it's all about. They're not going to let you, be doing biopsies or anything like that, but you can kind of start to see what's the workflow like, what's a typical day, do I like this, do I like working with the patients and the techs, and kind of just get a feel for how it is as a breast imager. And I found that very, very helpful, and it made my decision to go into radiology much easier to take that leap.
Absolutely. Anybody have anything else to add to that? I think those are all great points. Those are all fantastic points. We have another question from a viewer talking about kind of starting fellowship now in today's COVID environment. Obviously, this is different from what any of us, maybe except for Kimberly. Kimberly, you hit the tail end of it, right?
Yeah.
But you started out normally.
I started out normal, yeah.
So maybe, Kimberly, if you want to go into kind of the process of, how you navigated you were
Sure.
ground zero for COVID.
Yeah. So I was in New York City. So we got very, very busy with non-breast volume very fast, starting in late March, early April. So what we did is we changed all of our conferences to virtual. And then we did continue our breast imaging service with some changes to make it safer. So the volume was down in order to allow distancing between patient appointments. Eventually screening was paused for a short time, and we did remote readouts with our attendings. We did a lot of talking on the phone with our attendings, even if it felt silly because they're right across the hall, but we were, maintaining our distance and still doing that. And most of our conferences, or many of them, were fellow driven. So you were still very engaged in the conference process, even if we were not together. So tumor board every week was fellow presented. We would have different roundtable discussions with our breast imaging faculty. So that's obviously very interactive. So it was relatively easy for me to stay engaged on the breast imaging side. But if you're in a fellowship that doesn't have that, you might have to get creative with having more ways to connect with both your attendings and with your colleagues remotely, because it's very important to try to maintain that closeness with your colleagues as you continue through a challenging time. I know that it really helped me to get through everything to have my co-fellows and their support.
Yeah, I don't know how much we could add to that because you actually lived it. And at Allegheny Health Network right now, we don't have a fellow currently, but we have residents that are starting to rotate back on breast. And we've actually, we have different sites. We have 4 different sites that residents go to. And right now we just have them limited to the 2 sites where the reading room is big. And so we have one attending. And so we staff each site with 1, sometimes 2, but mostly 1 attending. And each one of these sites, the resident will sit at the opposite side of the room, and, readouts aren't as personable as they were before COVID started. I can say that. And our tumor board, it's getting more in person, but most of it's still virtual. We have our tumor board is actually resident, and a resident is paired up with the staff every week to run tumor board. And so that's, and then all of our conferences for the foreseeable future. I was just talking to the program director a little while ago, and all of our residency, we don't have fellowship specific program or lecture series, but all of our residency lectures are still virtual, and they will be virtual probably for the next year. But we'll see where the climate leads us. Anybody have anything else?
And I think that this really brings up an important topic that, or point that Kimberly and I think Matt, you brought up earlier too, is just really make some goals, because it's really easy to lose track if you're not talking to other people.
to sort of get behind in your reading, to get behind in your goals, and just to lose track of time, you know, with everything that's going on. So making the most out of the year, even though it's not ideal, it is best. We have one breast fellow who actually was, you know, on maternity leave for the last 3 months. So in April, I had her home study because I didn't think it was safe. And then our incoming fellow just had a baby in July. I haven't had experienced fellows with COVID, so it's interesting to hear what you guys are doing. But I can imagine that you could get really far behind, you know, if you don't keep track of your goals. You know,
definitely. You know, we're getting kind of towards the end here, almost to an hour. Does anybody want to? I mean, we've pretty much hit ad nauseum what it's like to be a breast fellow. You know, it's pretty much an apprenticeship, and you know, you want to start out, you know, you want to start out trying to learn as much as you can, and by the end of your fellowship, you should be pretty comfortable, you know, being autonomous as a breast imager. And so those are kind of, we talked about hitting small little goals on the way there, but that's beginning and end point is, you know, you want to learn how to be a breast imager, and at the end you want to be a breast imager. And how you get there in between is, you know, based off of what you expect to get out of it. In that kind of same vein, do we have anything that we want to talk about as far as learning materials? We've talked about, you know, showing up and putting in effort or whatnot. Are there specific things, you know, I can start? I always tell residents even that rotate on the breast imaging service that read the BI-RADS manual front to cover. That's number one. Take the BI-RADS manual home over a weekend and just look at the pictures and see, okay, oh, that's what round versus pleomorphic versus fine linear branching looks like. That's what, you know, that's what a mass versus a focal asymmetry is. You know, read the BI-RADS manual. That's number one. You know, learn the lingo before you start getting into the nitty gritty, in my opinion. Anybody else have anything to add to that?
There's a really good, oh, go ahead.
No, you're okay. I echo that the BI-RADS manual is great. I read it for another time when I started fellowship, and then referred to it all the time because sometimes you can get down a path of looking at something and being like, wait, how is this really supposed to look? And just like being able to flip through and check is really great. Another great resource that we had was through our breast surgery fellowship. They have a bunch of articles that are like their must-read literature in breast surgery, and a lot of those have to do with breast imaging as well. So ask around, even if ask your breast surgeons, your breast attendings, kind of if they have some must-read articles. So those are really helpful as well. And I'm actually working with a few different programs right now to kind of put something global together for reading for fellows. So stay tuned for that in the future.
Cool.
Hopefully that'll be helpful.
Let us know.
Yeah, I will let you know. Hopefully that'll be helpful. Sorry, Tiff, I cut you off. Go ahead.
No, I was going to say, you know, the BI-RADS manual I think was extremely useful on a day-to-day, as well as for the certifying exam, especially if you're planning on taking, you know, the breast sections. There's a section, I think, on like management or something where they talk about like these interests, like it's like a Q&A sort of thing. And they're like, okay, what if I have a patient who is this, this, and this? Like, how do I code this? So those are really interesting sections too. I think as a resident, when I read BI-RADS, I looked mostly at lingo. But there's a whole like management section that's really useful too. And then I also used like there's a breast imaging like case review series. I feel like that was a series I used for boards. But the breast imaging one is actually pretty useful as well. And there's also another book by Shaw, S-H-A-H, that has really good like Q&A. There's a question book, and then I think like a regular didactic sort of book. Obviously, when you first start, you know, you're going to be very busy just getting used to your new surroundings, meeting people, the logistics. But whenever you start having time to read, those are definitely the ones that I think I would hit up.
Yeah, the Shaw book, that's the core review series, right?
Yes.
Yeah, that's fantastic. I use that. I think it's great for, you know, boards purposes. And I used Dr. Berg's book as kind of a reference book because it's so detailed and so big. I mean, you can't really sit down and read it cover to cover. At least I can't. It's too much information. But really, if you have a specific topic that you have in mind, that book is fantastic as a reference.
I think
the action in book form.
I think also the ACR appropriateness criteria, making sure like, you know, maybe the first month that you're in your fellowship to go through all of those, not just, you know, there's a nice write-up with each of them. So just making sure that you know all of the scenarios and, you know, the workup through that.
I think it's important. You know, there's lots of good resources out there, and these are great ones. The one that I read front to cover my fellowship year is Copans. I brought visual tools today. But this book, I mean, copyright 2008, but it you know, it's starting to get outdated. I think it was still pretty, you know, up to date, you know, as of 2 years ago. But I think the main point is pick something and stick to it. You know, if you jump around, you know, you can jump around, but if you pick a book, like I that was one of my goals, read this book. And, you know, I got through most of it. You know, I don't think I read, you know, every page, but most of the important stuff. You know, if you're an article person, there's the Journal of Breast Imaging that is released every month, right? It's every 2 months. It's six issues a year. If you're a member of SBI, you get this either in print form or in digital form. So, I mean, there's lots of resources out there. It's important that, you know, you don't get bogged down and, oh, I have to read everything. Pick something and stick with it. Pick something that works. If you're a case person, pick the case review series. If you're a prose person, pick Copans. If you like reading outlines, pick the Berg book, because they all have a lot of the same knowledge. And so find something and stick to it is my advice. Anybody else have anything to add to that? I mean, the last question that I had kind of just ties up everything in that, you know, you do the fellowship because you want to be a breast imager, you want to find a job. When is the best time to look for a job?
During
Earlier
COVID,
the better.
when? Probably the earlier the better, exactly.
Absolutely. Now, yesterday. The job market is great, especially for breast imagers. Private practices and academic jobs galore. Go to the SBI website, and they have new listings daily. If you're interested in one, it's never too early to reach out. I mean, I'm kind of a go-getter from that standpoint, but I was, you know, at one point I thought I wanted to live in Florida. So I reached out to a couple places down in Florida when I was like a third-year resident. Hey, you know, just wanted to put myself on your radar. You know, it's never all they can say is no, or this person's annoying, get away from me.
I think most practices are very receptive to people, even if you're just sending out feelers and just saying, you know, I'm potentially interested in this area. Or if there's an area that you know you want to be in geographically, the earlier you reach out, the better position you're going to be in.
Definitely. Does anybody have anything else to add? I think this was a fantastic, very informative discussion. I really enjoyed talking to you all. Any other tidbits that we haven't hit? I think that, you know, people that are watching this for the first time or rewatching it, we've run the gamut of how to be successful as a breast fellow. Anybody have anything else to add?
One last thing I think is a good bit of advice. One of my attendings actually let me kind of fly solo at the end of fellowship, and she was great. She was one of my mentors, fantastic. And really towards the end, she would let me do diets by myself, and she'd kind of be off in the background, but I was literally did everything on my own, and it is kind of unnerving at first, but it is so helpful. So if you can find somebody that will help you in that sort of way, kind of let you have a little bit more autonomy, find that. It was
awesome.
It's very helpful. But thanks for having me, guys. This was great.
Absolutely. You know, so this was week 5. Next week, it's a nice little segue and a nice little transition into our next topic, which is being hosted by Amy Patel. And she has a guest with her as well next week. The topic will be the transition between fellowship and attending. So it's a nice transition from today's talk into next week. So I
I'll be
hope if you
watching
enjoyed
that.
today, that you'll join us again next week for the continuation of this discussion and topic.
Great. Thank you so much, everyone. What a great session.
you.
Thank you.
Thank you.
Thank you guys. Have a great one.
Good night.
Bye.